Dr. Hrushka and Paragi, are you both set to go?
I am.
I'm good, thank you.
All right. One more minute and then we'll get it underway. All right, I think we'll get this morning's session underway. Welcome everyone to the Women's Health Matters webinar series. This is part 4, and this is the ups and downs of sex with Dr. Hrushka. Sorry, I just lost my screen. I'm gonna wing it. So at our core, the Women's Health Coalition is an advocacy organization. And when we think advocacy, we are influenced by women's stories. We are informed by the expertise of healthcare professionals. And then we advance that advocacy agenda through evidence-based recommendations to government and to health system influencers. Recently, just a few weeks ago, we celebrated the inaugural Women's Health Week in May 8th to 15th. And for 1 week, we engaged businesses, community, government, and Albertans to raise awareness and increase understanding of the women's experiences in sexual, menstrual, and reproductive health. We know we are gaining ground in our advocacy efforts when women can tell their story and guide their healthcare experience with more authority. When we see signs that the stigma and gender bias associated with menstrual, reproductive, and sexual health is lessening. When workplaces are prompted to examine policies that may inhibit open dialogue and possibly even they can create programs to encourage more open interactions and conversations. And the healthcare community starts to pull together to embrace women's health as a priority to ensure the system is accessible, easy to navigate, and patient-centered. When we know we're heading in the right direction, when we can foster collaboration between community leaders, healthcare professionals, and government to address barriers, gaps, and an unconscious bias in sexual, reproductive, and menstrual health. We can only do this with committed and passionate volunteers. We started in 2017, really got going in 2020, and we did that through a really core group of dedicated volunteers, and I am very happy to see many of them on the line today. And we have Paragi Shah, our Vice Chair, here today to provide us our introduction of our guest speaker.
Thank you, Carmen. Perfect, thank you, Carmen. Dr. Cory Hrushka is a registered psychologist who has received his undergraduate degree from the University of Alberta, as well as his graduate degree from the University of Minnesota. Cory has worked in a nonprofit sector at community counseling agencies and also has taught at Grant MacEwan University, as well as worked at the federal maximum security institutions and psychiatric facilities. In 1997, Dr. Cory Hrushka opened his practice, now known as Insight Psychological Inc., with 40 therapists serving clients in Edmonton and Calgary area. He works with children, adolescents, adults, couples, and families, and he's a certified sex therapist, and his specialty is in sexual issues. He's also been recognized like a celebrity through regular guest appearances on Phone Folk Access, Help TV, Breakfast Television, CBC TV, and radio and A Channel, and also has been quoted in many of local newspapers. So quite a celebrity we have here today with us. Cory's philosophy is based on client-centered approach to support effective change in areas that are required and needed. So without further ado, please welcome Dr. Cory Hrushka. And I really hope I pronounced your name correctly.
You did fine. Hello. So maybe I should just kind of maybe explain a little bit about maybe sex therapy. So since my area is in sexuality, there's only one really governing body that kind of requires individuals to get training and certification in sex therapy, and that's AASECT. It's the only one that I know that in North America. And so part of the process is, in order to become a sex therapist, you need to become typically a psychologist or a therapist first, and then you go through an additional training and hours. Now, I have my title also is a Diplomate of Sex Therapy. So years ago, when I started the original training, the standards were actually even higher. And so because I guess it was higher, a lot of individuals didn't want to go through a lot of the process. I was just a sex nerd, I guess, at that time. And so what happened is they kind of lowered some of the standards. And so the old term, the diplomat status, was kind of grandfathered in to those individuals that did all the more work. And so part of that is I am a certified sex therapist and also diplomat status, which basically means, I do a lot of work in sexuality. I've done a lot of the certification process through AASECT. And if you're looking for a sex therapist, I encourage you, although the term sex therapist is not really a registered title, normally what I want to recommend people to look for if you're looking for a good sex therapist or in the sexuality area, someone who's kind of AASECT certified or who has gone through some of the AASECT training, that would be, to me, probably the top standard in terms of the dynamics. I know some individuals who may do sex therapy or kind of practice some of the sexuality stuff, and it all depends on how focused on what they're doing. The main focus on AASECT is to help individuals do the applied sex therapy stuff. And so just something just for you audience to be aware of in terms of training and models that kind of people follow. So I'm going to be talking a little bit about, well, pun intended, yes, the ups and downs of sex. And these are the factors influencing sexual functioning. And the main focus here, although most of the historical research is on men, a lot more new research is coming out for women and being able to do that. And so one of the complexities as women is, in my experience, is women's sexuality is a lot more complex than typical male sexuality. So it's harder to actually research and get a good understanding and what that actually means, because there's so many variables that can play with it. And so I'm going to kind of talk a little bit about the variables. And then what I'm going to do is I'm going to leave a bunch of time at the end for us to be able to have some good open conversations, asking some questions, go down any of the rabbit holes or up the rabbit holes, kind of pun intended there. As I also have we have a podcast called Up the Rabbit Hole with Dr. Cory Hrushka, which we just started, I think in January it might have been. And so we're running those typically, I think, once a month right now. And so we got one coming out this week. I think we got about 4 or 5 coming right now that are already on there. And we have a different topic every session. And we kind of, again, go first down the rabbit holes and then back up to try to help make an understanding of some of the stuff that's going on to help people be well educated. So, and feel free to ask questions throughout, because some of the stuff may apply right to the stuff I'm talking about. I'm okay with kind of being flexible and playful in this process. And so also just to be aware of, as I talk about some of the stuff, be aware that there will be some generalizations. And so not everyone's going to fit in the same categories or in the same styles as I talk about. And the best way I'd kind of say is, when we're looking at kind of sexuality, think of sexuality kind of from a continuum, from I'll call it a masculinized lens to a feminized lens. And so people may kind of, in this one variable, may kind of vary back and forth in different areas at different levels. And so that's kind of like when I say sometimes more like a masculinized trait, research tends to show, the more masculinized someone's brain is, the more these behaviors tend to show themselves. The more feminized, they are, the more these typical behaviors tend to show. But you can have a whole mixture of those traits within your mind and your brain and behaviors. And so that's just a little bit of an understanding I want to throw out there to help people kind of get a gauge on when I'm talking about, either male or female or masculine and feminine. Or again, there's a bunch of traits associated with it, but it's not a guarantee that you're going to even run that. I have some women that run more masculine overall and some men that run more feminized overall. And I guess the other reason I kind of say that is to also say, as we always, when we're looking at just the biology of sex and gender, as a male perspective, we all start with a female template, and then testosterone masculinizes our brain and body parts. So we have that feminization start, and then masculinization occurs. And that may occur in different parts of our brain and or body, and it may not. And so we might have different parts of all that throughout our system. And all of that will impact our sexuality, our mindsets, our response style. And so I'll go through a bunch of those traits and well, a bunch of those, and kind of just seeing how they influence. So I'm going to start off with a little cartoon. Funny as we talk, some things haven't changed in a million years. And so there is still a truth to this, funny as it sounds. As when we look at masculinized and feminized brains, typically, and this is where I'm getting to that complexity, is the more masculinized brains and behavior we tend to see, the more we have what's called, I call it linear, sequential, task-focused, goal-oriented situations. And so when we look at that, there's kind of there's a bit of bioevolutionary stuff running here. And so when we have that, is the goal for lots of men is for the sexuality. Even though a lot of them may like the intimacy component, it's the action component that kind of, the actionable is kind of the one that they tend to be chasing. With women, though, it tends to be a lot more emotional, relational, and kind of process. So when we look in the jungle, what you'll see is, for that access to reproduction, typically the male will have to go do the dance. If we're looking at some of the birds, if they don't do the dance or don't do the chirp right, they don't fulfill those requirements, and there's no interest, and therefore there's not going to be access to reproduction. And so when we're doing this, there's this intermingling and interplay that's constantly going. And funny as it says, even though a lot of people think we have a lot of control over our own sexuality and what's going on, there is so many underlying variables that are behind the scenes that from a bioevolutionary perspective that a lot of people are not aware of, and that we are highly influenced by, such as copulins. So women release copulins during ovulation, which male brains can pick up. And, there's some research supporting that men can sense when women are ovulating, and even in facial features, where women's faces become more feminized during ovulation and become less feminized outside of ovulation range. And males are perceptive enough from a visual perspective, because males tend to be a lot more visual oriented in terms of what arouses them, to those little nuances that occur. And so there's a whole bunch of interesting research kind of supporting kind of the what tends to respond and what tends to influence kind of arousal dynamics. So just a little bit of a playful about this is, as we go through this, these are the tendencies. Doesn't mean it's the black and whites. And so what I might encourage you to do is think about yourself as how you fit into some of these tendencies, and whether they're more masculinized, goal-oriented, or feminized, relational-oriented, process-oriented kind of stuff. So just to playfully look at that. Now, originally, Masters and Johnson, if I'm going to look at just, the original research supporting arousal cycles and response, Masters and Johnson's originally talked about kind of the sexual arousal cycle. And so funny as this sounds, so it typically starts with excitement. It moves up from excitement to a plateau. That plateau moves up after a while to orgasm, where there's a higher level of sensitivity and kind of that response, and then it kind of drops down to resolution. Now, in women, there's a much higher chance. The advantage of women, I would say, is overall, women have a much better, I'll call it, physiology for sexuality than men do. You tend to get better orgasms, you get stronger orgasms, you have the potential for having multiple orgasms much easier than males do. And so with this multiple orgasm model, is a lot of women can be multiply orgasmic. A lot of them just haven't trained themselves to be able to go there. And so men can be, but it's much more rare, and or there are ways to allow men to become multiply orgasmic, but it usually requires some physical maneuvering. For instance, if we're going to do, I call it the perineum push. So if you actually stop ejaculation from occurring, you can have males actually become multi-orgasmic without multi-ejaculatory. So that's one of the only ways that you'll find that men's, you can do it through some tantric kind of experiences, but that's like a skill set that that's way beyond even my level of getting to. So, and the other thing to realize that even in this dynamic, most people think that touch has to be a component of sexual arousal or orgasm, and it doesn't have to be. All you need is the big organ here is mind. People will frequently, if you have a wet dream for men, women can have wet dreams too, but you can have orgasmic response just through thought. And there was a fascinating research that they didn't believe her, where they put a tantric sex expert, I guess, into a MRI chamber, and they watched her brain and tested her response, because she said she could be multiply orgasmic within, I think it was ultimately it's seconds, and they didn't believe her, and so they popped her into the machine, watched her, and I think she hit the first orgasm within 30 seconds, and then she was having them about 12 seconds apart after that, and they hit 12, and they said, okay, we believe you, the MRI supports it, done. And all she did was lay there and just kind of psychologically facilitate that process through, I think it was a bit of contractions and mindset in that system. So the potential for a lot of what we experience is really way beyond what a lot of people actually do, because most people tend to have, I call it okay sex, or just good enough sex. And we lower our standards over time just because we tend to be kind of more busy. But again, this is your old model. It was actually based on more of a male model. I'm sure they added in the multiple orgasmics for some individuals, which are mostly the women. But more recently, and although there's a few other models in there, the one that applies best that they found to women would be by Rosemary Basson. And so she kind of brought this model out when a lot of the old model didn't apply too well. And so what happened is this model really explains the complexity and the, I'll almost say the potential or availability for women's sexuality and arousal to kind of occur. And so if we look through this model, we can see, it doesn't have a start point. It really is kind of like an open-ended circle where individuals, particularly females, I would say some men may respond to this, but it's by far the majority of a women response model. Emotional intimacy could be one of the things that could lead to the sexual arousal. And that might only be the thing that's needed. Someone, if there's a level of sexual neutrality, there could be a receptivity to it, which would allow that to kind of happen. If there's someone who's pursuing, if that's one of their arousal styles and dynamics. It could be just biological influences. Something could be physically touching you, or the visual dynamics may occur as well. And that could be another thing that could be a factor that's influencing and facilitating women's sensuality, sexuality, and arousal as well. And even though I've looked at this numerous times and I've tried to understand it, it still kind of is almost I'm still amazed and still confused all at the same time about all the potential and what it actually means. And so, but what the concept here is, if there's a level of historical, emotional, or physical satisfaction, there could be a level of desire, which basically already facilitates a higher level of arousal before, which then can facilitate more arousal. But generally what I would say is when I'm dealing with a lot of women is, the most common pattern that I would see is it starts off with, if there's a level of emotional intimacy and there's no other contaminants kind of going in, then the potential for responsive sex tends to be a lot more higher. And so a lot of women, when we're talking about that, say they don't tend to have a sexual arousal or desire at all. And I think there's a lot of research supporting that for the majority, unlike kind of initiatory sex, a lot of women tend to respond more in a responsive style, which means when the dance is done, when the intimacy is present, when there's all the factors that are kind of there, then the recipe percolates and arousal and or desire fires up. They don't tend to run the same way as men overall, as again, men tend to be a lot more visual in nature. And so I'll kind of talk a little bit about some of the differences here that kind of play with us. So what causes some of the differences? Well, first of all, I'd say is there's, the testosterone androgen levels. No, that's more in men when we look at that, because they've tried to say is, hey, why don't we just increase testosterone levels in women and maybe they'll be as horny as well. And what they found is, no. In some women it did. I have some women who they've upped their testosterone levels to a little bit higher levels, and then they found a very strong response to desire and sexuality. But a lot of them, it didn't do much. It just it's just looking at that then. But with men, as we add testosterone to men, they become a lot more more aggressive and are more sexual in terms of those dynamics. So you can get into that hypersexuality when we're looking at women. But women have androgen levels in their system, and they're also a lot more, if not, I think 400 times more, 4 times more, 400% more, but 4 times more reactive, responsive to androgen levels in their system is my understanding. So they don't need as much. And when I have transgender individuals switching over, what I see is it's a fascinating process to see as my female to male trans individuals add testosterone, how their mindset has changed quite a bit, and they wouldn't have believed it if they didn't experience it themselves. I had some clients where, and there's even a dynamic where they says, there's this need to put their clitoris in holes or the lens, which is like they never would have experienced before. They start seeing things a lot more when they're looking at breasts or these shapes, and these are those visual dynamics that men's brains tend to respond to a lot more. And I'll talk more again a little bit about that. Health is another one. So, issues such as diabetes, pain, or even body response to that can really put a damper on sex drive. The medications that typically go with diabetes and pain are famous for killing sexual desire as well. Endorphins or opiates, and anti-diabetes or heart response issues too, decreasing blood pressure. All of those typically will have an impact on sex drive. So if you're looking at kind of your own, what you're taking, what's your age, what are those responses, how are those impacting? As we get older, our bodies don't want to do the same things that we used to do in the past or can do. Bending over becomes sometimes a big pain in the butt. And so therefore it increases that likelihood that we're going to have issues or not want to it just because we're not paying attention to our environment from a sexuality perspective. We're going internal more to kind of feel those feelings and those physical responses. Medication and drugs, I'm going to talk a little bit later on some of the effects that those can have, because they tend to have probably the most common and easiest responses to kind of pick off, especially with my antidepressant meds, which are the most commonly used. There is some research also with antipsychotics killing sex drive, because they're also pretty good at famous for that too. But the SSRIs and even the tricyclics are probably the biggest problem issues that I'll see when people are coming in and wondering why their sexual functioning is not working the way it used to, or it is. Also looking at particular sexual activity. So that kind of goes into kind of what we call arousal templates. And so arousal templates are the things that turn you on, and that could be based on your history of what you're seeing, what you've done. And so you might not be interested in certain activities, whereas other activities you might be quite, excited to kind of think about or do. And so those can impact just your sexual drive. If your partner only wants to do A or B, and you're interested in C, D, and E, you may not have that desire because it's just not in your kind of your appetite or the repertoire of your partner's dynamic or interest either. Mindset to me would be one of the bigger ones. You know, if there's a history of anger or issues, or and you're not happy with your partner in the current circumstance, that mindset is going to be significantly impacting your sex drive and at that time. And if there's unresolved emotional issues and that resentment, it's another common contaminant that I'll typically see in relationships causing sex drive problems. I'll go a few of these a little bit more later on too. So now people kind of wonder, like, how does supply and demand go? This is a funny process that I also see commonly in session, where the higher the supply, the lower the demand. And so initially in the beginnings of relationships, you know, we have kind of what we call, you know, there's the infatuation phase, or I'm forgetting on the beginning stages of love. There's a beginning stage of love, which is just kind of that love is blind concept. And so limerence is what it's called. And so during limerence, sex drives are a lot more aligned with each other in terms of partners. But what happens once that initial 2 months to typically pushing it at 2 to 3 years occurs, or certain kind of circumstances occur, interestingly, like marriage or kids and or work, as soon as those influences kind of come in, the interest tends to go down. And what happens is, you know, although men tend to have a higher sex drive due to the testosterone stuff, depending on, you know, the history and the relationship, the higher their desire, the more that the person in the lower interest position actually starts to have more power. And which means basically I can pretty much get it whenever I want. Therefore, why do I need to go chase her? Or, you know, whenever I decide to, it'll be available for me. And so with that high demand or high supply kind of process, it becomes unattractive lots of times, because it's almost like chasing easy prey. It's no longer a challenge. There's no interest. It doesn't require much energy. And so a lot of people like this chase kind of related to growth. And so I have a growth model we might play with, you know, as if we have time near the end. But what happens is, as people kind of play with, you know, the challenge and the interest, there's that little bit of a fight, that little bit of a play dynamic of not something that's easy. It's like fishing. If you kind of go fishing and you throw your hook in and the fish bites every second, every time that you're kind of doing it, it's not really any enjoyable, because there's no challenge to it. There's no, you know, it's really easy. And so what I'm trying to work with a lot of women is, when they have that high position of power because they have the low demand, is I want them to learn how to utilize that and wield that power in a healthy way to help the other partner with a high supply switch that down to either playfully lowering the supply on purpose, or setting challenges in place to be able to kind of facilitate some new dynamics, just because it's kind of gotten mundane over time, or just too easy. As couples kind of move on in the years, typically you'll see environmental influences become a lot more of a factor, and stress too, which typically looks like, as people have kids, as soon as people have kids, typically the sex drive and sex levels and rates actually drop quite a bit. More in women. Women tend to aim their interest more towards their children and child rearing, whereas the men tend to still have, you know, their same level of, you know, desire commonly. Because women tend to be a lot more susceptible to environmental influences, and again, there's some bioevolutionary dynamics attached to this, they tend to be a lot more focused on if the lights are on, if the windows might be open, if someone might hear, if the kids, and again, that might be a more common pattern, but I have some women that's kind of the things that turn them on. It's the chance of getting caught, or the taboos. So it's, again, just being aware that, again, these two continuums, or where you are on that continuum of how these affect you, because some may affect you strongly and some may not as much. Stress is a big killer for differences in sex drive, particularly with women who tend to have higher levels of anxiety. Men are a little bit more with depression and stuff like that, but stress response kills pretty much any motivation, drive, and sex drive to do anything else but kind of alleviate the stress response. When I'm doing kind of the historical stuff, I'm also looking at sexual history, which could mean, what did you learn about sex? What was your history like when you were growing up? What were you taught by your parents about sexuality. And we were just earlier talking playfully before about how women, you know, in terms of even masturbation, how what they learned about masturbation, or the lens of how okay it is to masturbate, is different in boys and girls kind of growing up. And so that learning sets the stage for what kind of, you know, are you going to be a good girl? Or are you going to be a bad girl? You know, is there a history of abuse? So, you know, with the rates being much higher for women, I think it's 1 in 3 of women by the age of 18 have been, you know, a survivor of sexual abuse, versus about 1 in 5, I believe, for boys. Women are much more susceptible to having negative sexual abuse experiences that can impact their arousal templates and those sexuality behaviors. Now, sometimes it can reverse it. It can hypersexualize it, but it partly all depends on how they've experienced that, what they've done it, how they've worked it through, and what it means to them. Religiosity is also another one. The more fundamental the religion, or the more conservative the religion, the more those belief systems, especially if they're regarding sexuality, impact you through kind of going forward. And again, there is a bias against, you know, men and women in terms of what they've learned about from religion, in terms of what you can do and what's okay. Sometimes I playfully kind of state that, you know, churches keep me very busy, especially the conservative ones, just because of the high levels of guilt sometimes associated with religiosity, and the effect it has on just killing sex drive, or even a willingness to explore sexuality and one's body. And the last main kind of sex drive cause, so to speak, or influencer, is kind of levels of intimacy in the relationship. And this is non-sexual. So when I say intimacy, for me, I don't mean sex. These are the closeness, bonding, connectedness kind of dynamics that I'm looking for when I'm talking about how is the relationship. Is the relationship close? Is there cuddling, closeness, bonding? Is there kissing, holding hands? What's that playful dynamic? And if that is present, then it tends to, again, facilitate a higher likelihood of sexuality. However, there is a condition to that, is that sometimes high levels of intimacy can actually fight passionate sex. It's a damper on it. It's almost like having it's like having sex with your best friend, or with a parent, or with a brother or sibling. If you have a really close, intimate, kind of like brotherly relationship or sisterly relationship with your partner, it loses that level of passionate foundation that people are willing to go to have passionate sex. And so when I'm looking at that, and we talk about sexuality, I mean, I'll talk a little bit more about that, but it's, as we're looking at intimacy, just be aware of how those play with you. Some people will kill intimacy kills sex drive. Some, it facilitates it and opens the door up quite well. So a little bit about kind of some tidbits, a little bit about arousal and desire issues, and these are common arousal templates. And so when we're looking at some of this bioevolutionary system, we're talking about, if you want to understand, and I guess that's why I laugh when I say women have so much more power in the sensuality, sexuality field than they really realize, except the ones who know how to utilize it, and then they know exactly what's going on. But men tend to be primarily visual in nature. And so a lot of women worry about, oh, I'm too fat, I'm overweight, or, you know, I'm not attractive in a lot of those dynamics. And so a funny little thing about males' brains is, for some bioevolutionary reason, it's not about the weight, it's about the hip to waist ratio. So as long as you can facilitate as close to a 70% hip to waist ratio, the more male brains pay attention to it and get aroused, whether we like it or not. And it's a funny process, because I think a lot of women that when I'm seeing in session, is they will get jealous when men look at, you know, if there's rubbernecking for a long time, then they get quite jealous. But when we're looking at this dynamic, is men's brains are almost hardwired to pick off certain body components, body proportions, particular issues. And same thing with, we have, I mean, the top 10 would be, you get the 70% hip to waist ratio, long legs, welcome to high heel shoes and tight calves. So those are these things that facilitate male brain arousal. Long hair, Large eyes, actually, and we're looking at even dilated pupils. When we're looking at marketing perspectives, all people can tend to see and will actually like a dilated pupil picture of someone over a less dilated pupil picture of someone. And so those kind of tend to fire off in our brain with a bit of arousal. Again, the high heels, calves, arched back, which we call kind of lordosis. And so as women will stand up straight and kind of arch their back, chest out, that is almost like a trigger firing for male brains to kind of think, reproduction in a way. And so high heels tend to make people stand up a lot stronger, straighter in that system, and jut out the chest and stick out the bum, which are, again, one of those things that males' brains would tend to be highly attracted to. And the open or long neck. So that's where you get the V-neck shirts and the V dynamics, as well as kind of almost a level of vulnerability around the neck. And so these are just, again, these are interesting uncontrolled brain responses. And this is what porn really kind of markets to. This is the kind of stuff that you'll typically see where male brains tend to run, because I will call porn kind of the from a food perspective, it's a high quality gourmet food delivered to your house 24 hours a day free of charge, and you don't get full. It's like nothing really competes with that porn dynamic when you're fulfilling these from a visual arousal perspective, which is very different from a relational perspective. Women's templates, and I've kind of talked a little bit about this, but there is some support for a V shape. So there's that, that masculine, strong upper body dynamic V shape, but it tends to be more from a relational and a status dynamic. So they've done some interesting research where, the higher the status or the financial status that the person is, if they're male, the more the females will actually find them viable, attractive. And what's happened is they've even done some interesting research where even if you have a billionaire female, in order for her to find someone more physically or more attractive relationally, they have to be a higher status and or a higher financial status than she is for that to naturally fire up. And so a lot of these very wealthy women are having some difficulties unless they're having some boy toys. But it's from a relational perspective, it's almost, and again, some of this is that, some bioevolutionary theory that's kind of supporting some of this. They've even done stuff to look at that comparatively between men, is where they've taken, video, or they've taken some research and they've said, here's an unattractive, an average, and a highly attractive physically male and or a female, and they've only changed one variable. And the variable was financial status / job position. And when they looked at the differences of that, they took like an unattractive male and went up from ratings. So they said, here women, here's an unattractive, average, and male attractive. Here's the rate. Rate them on their scale from 0 to 10. And they kind of went 3, 5, 9. And then they changed the variable to say is the unattractive individual actually is like a computer engineer making $250,000 a year. The average guy is like a systems analyst making, $100,000. And then the really attractive guy is a bagger at a grocery store. And then when they had the women re-rate them right after that, then they went, oh, rules all changed. It actually went 9, 5, 3. And so they reversed the whole level of dynamic based on financial status and or job position. They did that with men, same kind of status dynamics. The 9, 3, 5, 9 stayed 3, 5, 9, no matter what variables they added in for the financial status or economic status. And so there's some differences in terms of the general female response in terms of that. The other one I commented about was the healthy alpha relational style. And so this would be someone who is typically confident, strong, or knowing themselves, being willing to be assertive and being able to move forward in terms of what they want. And then finally, kind of the intimacy base. If someone who is caring and nurturing and supportive and having a close feeling, physical and or emotional connectivity to them, these are the ones that typically female arousal templates tend to fire up a lot more on going forward. Now, I mentioned earlier about antidepressants. And so this is something that I really encourage people to, this is probably the most fascinating study that I've seen regarding sexual functioning and kind of biology stuff is a lot of physicians that I'm working with don't know. There's a good meta-analysis, and this is by Cherezian, I can find the name if we really want. It was supposed to be on the bottom here, but when they made it all pretty for you guys, they didn't put in the reference that I had before. Sierra and Chazy, I think. And so what they found is when we're looking at certain kind of antidepressants, and most of these are SSRIs, there are a few, I think, a tricyclic. But what we're looking at is you can see the big difference in terms of total sexual dysfunction. This would be percentage. Although the majority of this is strongly more associated with men, there's still a general flavor commonly with women in terms of the same pattern. So it is still very similar, just more pronounced in men response. But you know, in this groups like citalopram, venlafaxine, you know, we're running about 20 to 27% of total sexual dysfunction. So out of 100 people, almost 30 individuals of that are having complete sexual dysfunction issues from being on these medications. Down to some of the other ones, you know, bupropion, which is Wellbutrin, you know, almost having, you know, not even a % kind of difference. And so when we're looking at each one of these, some of these medications will be used to help, you know, some sexual side effects if there's functioning issues. So for instance, if I'm going to go to desire, the biggest culprit that kills desire is citalopram. And that's more than half of the individuals complain about lack of desire once they get on that medication. And these are the top 5 that are kind of typically having some of those issues. And you can see, you know, venlafaxine, Seroquel, fluoxetine, paroxetine, this cluster are the ones that are famous for killing desire. So if you're on some of these medications, I really encourage you to take a peek to see what's going on and how this might be impacting. Again, some of these can be facilitated by the psychological components and counterbalanced or mitigated, but it still can impact it quite a bit. Sometimes what happens is it also numbs, there's a sensory or a numbing kind of component added to this. And that's when we get into sometimes the arousal stuff. So again, these are different medications. So if we're having arousal dynamics, which would be dilation and lubrication in women or erections in men, we're getting citalopram. If you really want to kill an erection or an arousal, citalopram is famous for it. Almost 82% have issues with arousal functioning issues. Again, there's a.
Is that, can I ask a question? Is that about dose? Like, is that relative to dosing?
Well, I think that, I mean, because there's a level, again, I'm not a doctor in this process, but typically you'll need to get a certain level to get like an effective level. And so everyone's going to have a little bit. But once you get to the effective level, then what happens is these are the common side effects. Now you can get, they'll dose up to maximum, but these would be average from my understanding. These are kind of average effective dosage levels for the average individual that's taking them. I mean, if you add more, I think it's going to impact it more, but that's kind of the pattern.
I just said please leave it until the end.
Is there another question there? So,
Dr. Hrushka, we had actually, that was just a bit of a blip. I'm going to do a bit of a time check for you because we know that there are a lot of questions coming in. So we've asked people to hold.
I will zoom through more of that. Hey. So,
okay.
That's no problem. So we have orgasmic dysfunction. So interestingly, again, 41% will have orgasmic dysfunction response with clomipramine, I believe. Now, paroxetine, sometimes individuals will use this actually to help, FYI, to help males who have premature ejaculation. So they don't have to take it on a regular basis, but they can take it kind of as needed. Like, you know, if you're taking Viagra, what will happen is it will kind of lengthen it by almost 200 to 300%. So that's another little antidepressant information. But I'll kind of move on. Sexual tipping model. So another model that's kind of helping support an understanding of what facilitates or suppresses, or incites versus suppresses. We have what's called a sexual tipping model. And so sexual inciters are those things that turn you on and fire you up. And so those could be, you know, technically there's no really good aphrodisiac drugs. Amphetamines kind of do some of that, but, you know, stimulation, testosterone, but most of them tend to be physiological inciters. The attractive partner, you know, stimulation, the fantasy, or no, they spelt it wrong. They screwed that up. sucks when I give it to other people to put psychological. So the top ones are physiological, the bottom ones are psychological. So we have kind of an attractive partner, the erotic stimulation, the fantasy, love, the courtship, the relationship stuff. On the flip side is, the suppressors are the things that slow us down and kind of suppress things. So these could be an unattractive partner, a negative thought, a medication, and stuff like that. And some individuals, although you might have some inciters, you might have a really attractive partner. If you have more suppressors, it's like brakes. The more brakes you have, the less likely you're able to kind of get things fired up. So I either have to work with couples or individuals to look at facilitating the inciters or kind of getting rid of some of those suppressors to kind of get that balance to things to fire up. Well, those are just some of the little tidbit for you able to kind of explore and look at. So again, kind of summarizing some of the earlier stuff, women's dysfunction, in my experience, tends to be a lot more relationally dependent, intimacy related, or historically based. Most women, interestingly, are not aware of when they're aroused, and most need more than penetration to have an orgasm. So 80% of women need clitoral stimulation to have an orgasm. The pros that women have are that they are much more flexible and adaptable regarding sexuality. They're more malleable. So if there are sexuality issues that are occurring, if they're open to it, female brains and women are a lot more able to kind of navigate and maneuver it. Men brains tend to be a lot more rigid and more restricted in terms of what they're willing to do or what they can do. If I'm looking at if it's low, then I want to look at assessing for desire or interest elsewhere. A lot of women say, oh, I don't have a sex drive. However, they're masturbating every day or every week, or they're looking at porn or erotica, or they find their neighbor or someone else at work quite interesting from a desire perspective. And so what I'm looking at is assessing for desire with your partner is not a good sample. I'm looking for how does it generalize outside of that environment, even if they don't feel guilty, even if they feel guilty about it. Playing with environmental interference to check on that, because usually these are the common ones: work, stress, conflict, light, curtains open. Even the kids in the house sometimes can impact that enough, and they're might not be fully aware of that. And a lot of women are very related to, between the depression and anxiety. We have validation, and so intimacy. Validation basically means I need you to validate me as being attractive for me to feel attractive enough to have desire. If I don't feel attractive, it just doesn't fire up. So men's initiative response sometimes validates women's feelings of levels of attractiveness, and that helps facilitate that rebound and that build back and forth. So if I'm looking at kind of some quick tests and checks regarding that, I'm going to go, so did it change? When did it change? If we're looking for your desire or your arousal response, and that's going to give you some kind of key components on like what might have happened at that time. It could be a fight, it could be an experience, it could be starting of a job or an issue. How consistent is it? I have people come in and it might not be working all the time. It works sometimes, it works not sometimes. I'm going to look at, is it a consistent issue or not? Because that's going to tell me how much of this is biological versus psychological or circumstantial / environmental. Masturbatory practices, how does your body run in arousal? If we're looking at, masturbation with or without porn or erotic or a romance text, how are they running that? So I can see how their bodies are running and their mind how is running that, because both high and low for me can indicate a pattern of what's going on. Again, what's the intimacy like? What's the frequency of sex, if at all? And I can tell you some stats and numbers, but I'll let you ask for those. Is there a desire for partner for others? The trauma history, high religiosity, and recent conflict. So those are the other ones. UEIs are unresolved emotional issues. So those are those things that are still bugging you that you can't get your mind off, that can impact you from even thinking or focusing on anything at that time. Now, a lot of people think, oh, good technique, good sex is good sex. One of the things about Peggy Kindplatz did a study in just recently, 2020, and they've looked at all the mature of the magnificent sex over kind of, I think, across Canada particularly. And the top 8 did not come into one of the things that most people thought. And the top 8 would be these kind of components: completely present in the moment and embodied, focus, absorbed with your partner, the connection, the alignment, being in sync, the merger of them, this deep sexual erotic intimacy, the communication, the empathy, the being genuine, authentic, and transparent, as well as vulnerability and surrender, a willingness to explore, the risk-taking and fun, and they called one transcendence and transformation. These are the 8 top components of magnificent sex, not penis size, not body, not technique, not stuff like those. Those are nice little add-ons. Those run in, I think, number 10 it starts. So again, the older you get, the more potential what we find is to have better, magnificent sex overall when you can do these, because this requires a level of maturity that a lot of younger individuals may not have in that same level. So some of the treatments quickly, some of the stuff I already talked about briefly, might have to look at a med change. Is it partner dependent? So I might have to do couple work or look at other options. I give a lot of masturbatory homework to kind of test and see what's going on to help cross-train or retrain responses. I'll do a lot of trauma work. So that, again, couple therapy, intimacy, working on intimacy, even teaching men how to do a lot more intimacy, because they tend to have a lot more weakness in that area, as well as communication skills. Men run around 7,000 words a day, I think, typically, and women are running about 20,000 words a day. And so if they're looking at communication as a level of intimacy, men tend to suck at that. Trauma work for history of the abuse dynamics, a lot of teaching and education, CBT regarding sexuality, lots of pictures. I might even refer to gyno or urology or pelvic floor physiotherapy to help either work on some of those components that might be causing some pain or issues. And then the other kind of main thing we do in sex therapy is to do a lot of sensate focus on erotic exposure or fantasy training. And sensate focus is a series of structured exercises to help cool down the emotional response, build trust, build playfulness, exploration, and build sensuality rather than sexuality in the beginning. And if you want some good resources, probably one of my favorite books here, Mating in Captivity by Esther Perel, talks a little bit about how sexuality really dies over relationships in the beginning. Come As You Are by Emily Nagoski is a good one, and Magnificent Sex. I've got a whole bunch of other ones, but that's kind of the main cluster that I would save for today to be able to play with that. And I will summarize and go from there. And I guess there's some questions. And Carmen, if you want to throw them at me, because
There are lots of questions coming in, and I think we're going to take a bit of a leap of faith, take a chance, have some fun, and do some risk taking as per your advice. And we're going to open it up a little bit more than we have in other webinars, the previous 3 webinars. And if people would like to ask their questions themselves, they can. We would ask that you raise your hand and then take your turn to speak. You'll have to turn off your own mic. You can also ask questions in the chat box, and I have some already that I'm going to pass on to you, Dr. Hrushka. But if somebody would like to be bold, brave, and ask their question outside of the chat box, then we're going to do that as well, because this is a great topic that often is harder for people to talk about. So we wanted to open up both avenues and see how that would work. So while people warm up for the questions they might want to ask you directly, I have a couple of questions that have come in, no, more than a couple that have come in already. How much of the arousal templates are part of misogyny and social conditioning?
Now, so when I talk about arousal templates, I'm going to give 2 kind of things, because are you talking about the female and or male ones? Because I have my 7 cluster when I'm going to look at female arousal templates, which would be certain personality styles. Like I have some women who want the Prince Charming. I also have other women who say, I want the Hell's Angel biker. I want them to, take me, throw them over their shoulder, and use me well. And the 2 sides look at each other like, are you some alien or not? And these are 2 different systems. And I think one of the interesting things that kind of opened up is when 50 Shades of Grey came open, how 50 Shades of Grey actually sold more books than Harry Potter, even though I think from what everyone is telling it, and I've read part of it, it wasn't really a very good, well-written book, but it was the topic and the willingness to go into those places and the nuances of kind of more risque. Those dynamics have been taboo. And so with that dynamic, there is some interesting bioevolutionary stuff that look very misogynistic. And I guess it can be, but then I'm looking at how do I incorporate some of those into a healthy lens, kind of like that. I'll call it like some of the healthy kink stuff versus the abusive dynamics that, you know, might be related to some of the misogyny dynamics.
Thank you
Hopefully
for that.
answers that question.
Yeah, you know, it's interpreting the question sometimes is a bit of an exercise in itself, but we have more. There is more than I have actually seen in any previous webinar. So hold on to the rails, you guys. This is going to be a fast ride to get through them all.
No pun intended.
Or maybe it was. Actually, one of the funniest things you said was something about sometimes bending over is a pain in the butt. And I know if we were sitting in a room and you were presenting this live, there would have been a lot of chuckles in that moment for the.
I get really bad with my job because there's lots of kind of playful innuendos or kind of double entendres that kind of come out, sometimes on purpose, sometimes it just comes with the job.
Okay, so a couple of questions. We have how do women learn, or where do women learn how to orgasm now versus in the past? And just how much pressure is there to orgasm? Like, how important is that in terms of the sexual engagement?
And again, now here's where I get down the rabbit hole. So I guess that could be a much more complicated question than you might initially think, because I think a lot of men, because they tend to be a lot more goal-oriented, aim for women to have an orgasm as part of that process if they're in a, you know, opposite sex kind of dynamic. And so rather than a process oriented, it's like, I just want to get the orgasm. If I did a good job. I got the goal. Ta-da. And so some women feel pressured to do that because the men are chasing that dynamic if in that system. I think a lot of women have become a lot more open regarding their sexuality, you know, expressing it, sex toys, that kind of is becoming a lot more prevalent now. And I think it's hard to tell because women tend to be more pleaser style in the relationships, even though the numbers are probably close. Like men, I think they found that there's about 40% of men actually are pleasers, you know, and which is a lot higher than I originally would have thought. But again, because that relational dynamic is happening, women tend to be feeling pressured, even though the guys may not be as pressuring. And so the question I say is this perceived pressure or is this actual pressure? And then kind of go from there, because that's where we get into some of that potential issue, right?
Thanks. Lots of things are going through my mind with that, even personally, and I'm going to go home and talk to my husband, but I'll get to that later. Steph has a question that she would like to ask you to directly. So Steph, can you please unmute?
Hi, can you hear me okay?
I can.
Okay, hey, curious about, like, there's lots of discussion around addiction to porn and things like that. I'm kind of curious, can a woman get addicted to a vibrator? Like, once you start using a vibrator, is that something that you should sort of like take out of your sex with your partner because you become reliant on it? Like, I guess I'm curious about that.
Maybe here, I'll explain it the best way I can. So the good news is you technically can't get addicted to something that's not ingestible. Now, however, your brain can respond and look like it's exactly an addicted dynamic. So if we're looking at porn, if we're getting orgasms, your body is releasing a whole bunch of chemicals during an orgasm and arousal response. And some of those include dopamine and endorphins. And can your body go through withdrawal if you're having too much of that, particularly with endorphins? But the dopamine response starts to train your brain to get anticipatory dynamics. And that where you get that thinking about it, can't stop thinking about it, you know, aiming and chasing it, kind of like your meth addict. This is just a lot smaller. When we're looking at, you know, from a sex perspective, we get a 200% dopamine spike, 250, sorry. Food, we get about 200. That way you can get, you know, that arousal, that craving, that dynamic for food. Sex is actually stronger of the primary reinforcers. So can you get addicted to it? Kind of, but it's not technically an addiction. It's kind of more like we call it an out of control sexual behavior, which becomes a dependency. But you can incorporate that into your relationship and sexuality. because that's going to be requiring someone else to, depending on what you're chasing. If you're looking at intimacy, I don't expect your vibrator to give you too much of that, but it might give you a really good orgasm. And so, you know, that a penis won't, or you know, a mouth won't. And so, yeah, I usually encourage people to watch is it's more of how much. You know, if you're doing this, hypersexuality is defined at 7 times a week. So that may not be a problem, but my first check is, can you stop for 2 weeks? Because usually your endorphins are going to go through your kicking and screaming starting at about day 2 or day 3. And then you can see actually if your body is hooked on it or not. And then how do you incorporate that into the relationship so that you're actually getting the best of both worlds and still getting all those components without kind of being reliant on it. It's just an add-on is usually what I recommend.
Okay, thanks.
Thank you for that, Stephanie, for the question, Stephanie, and the answer. So another question, are there women that simply can't orgasm? And if the answer to that is yes, then how do you make that okay within a physical relationship?
Anorgasmia, yeah, there is I'm trying to remember the stats. It might be less than 1% of women are truly anorgasmic. And that's usually due to just natural biology dynamics and variation. I would say in my years, I'm trying to think if I've actually seen one. A lot of them have never had orgasms, but once we've done the right combination of exercises and or whatever, you know, got rid of the breaks and facilitated the facilitators, we were able to get them to get experiences of orgasm quite happily. And even, you know, I had tearful, you know, hugs from clients who thank me profusely for their first experience that they've never had in the 40 some years before their life. Just from going home and kind of doing some stuff and learning how to do stuff. But in some cases, some people need additional stimulation just due to their nerve response. So kind of, I would say, is the equivalent of my industrial strength vibrators to really get that nerve response fired up. But again, most of it's psychological. And that's not, you have to chase orgasm. I don't want an orgasm to be the end all. It's just one component. You can have numerous cherries on your salad, you know, sundae if you wish, or you don't have to have any. And that's the difference between product versus process oriented sexuality. But I encourage you to we need to check out to see what might be stopping it and looking at if there's any of those breaks that might be stopping it or what we need to do to facilitate it more, just because your body might be a little bit more desensitized or it needs a few little kind of fine tuning to kind of get it to happen. But yeah, in theory, there is a possibility that it's like, nope, your body just doesn't work that way. But it's like I said, it's very, very minor. Statistically, it's possible, but I haven't seen one technically yet that I can recollect. Maybe 1 in 25 years that we couldn't get there.
I really appreciate that answer, because what it says to me is persevere. If you are a woman who hasn't yet had an orgasm, it's time to talk about it. It's time to talk about it with your spouse. It's time to talk about it with your doctor or psychologist or physiotherapist, because it is way, 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 way more normal to have orgasms, and the figuring out how is an important conversation to have. So thank you for that statistic, because I think it'll encourage some people to persevere. So another question. Can you give some examples of some masturbation homework that women can do? And I think this is kind of getting into that self-help phase of you know, tackling some of this.
Usually the first step I have is people watch other people, because everyone's going to have a different style. There's some good healthy videos. I mean, you can go to Pornhub. That may not be, you know, there's crap. There's a website for educational sexual videos, and they will have, you know, I'll say normal individuals masturbating and the wide range of what that looks like. And so that, you know, if you're going to watch the masters kind of do it, you need to kind of see what that may look like, because some people don't know what masturbation actually looks like, and it might be very gentle for one person and very vigorous for another. Depends on your templates, your body response, all that stuff. I think one of the good vibrators that I've seen is either the womanizer or the satisfier. It's kind of a clitoral suction masturbatory device. Usually in my experience from talking to the women and even the saleswomen who said she purposely, self-used it as well. It cuts the orgasm response time probably in half, if not to a third. So if it takes you 10 minutes, we'll get it down in 3, maybe 2. And so a lot of women have found that to be like surprisingly, because they stop. Women will get really close to it and then stop themselves. So it allows kind of just, it's a new dynamic because it's very much more clitoral, and it's a relatively new vibrator in that style versus more traditional insertables, because you don't have a lot of sensory receptors internally, just pressure. It's all on the outside 1/3 and clitoral dynamics, and that's where all the nerve endings are. So it's just really playing with that one to kind of do that. So it's a lot of exploration, because every woman, like if I'm looking at masturbatory with men, they're very, very similar. There's not as much variability. When I look at masturbation styles and what works with women, it's a lot more variable. So you got to do a lot more experimenting and exploring, whether it's, feather light to, jackhammer heavy, whatever that might look like, and whatever that kind of the intensity. So that's kind of the quick nutshell for that.
Okay, well, thank you for that. And you said it rather quickly. I'm going to make a commitment to the audience that we will search down that website and those resources and get them on the Women's Health Coalition website, so that people don't have to rely on Pornhub and can actually go to the masters as you stated. So I have another question. This is more of a clinical one. Will exercise help reverse some of the sexual dysfunction experienced with antidepressants? Because you said depression causes a lack of desire, and antidepressants cause a lack of desire. What are the things, is exercise, will that help? Are there other things that could help?
I think exercise can be a component of that. Depends on how like exercise will improve mood, it'll improve vascularity, improve a little bit of testosterone too. So it does fire people up a little bit more. It gets your blood going and adrenaline, which sometimes could be enough just to start that process off. Sometimes if you're on antidepressants and it's causing a sexual issue, sometimes they'll give you Wellbutrin is the common one to help kill some of the side effects of SSRIs. It's the kind of the happy horny drug. It's a dopamine reuptake inhibitor. And so it helps facilitate that pleasure response that a lot of the SSRIs tend to give. And so not that you want to go on a second medication, but it also, what they find is it increases orgasmic response as well. I would say exercise is a partial component. It might not be the big answer, but it's definitely a positive.
All right. So here's a question. If a couple is having satisfactory sex, but would like to have magnificent sex, I think you've raised the bar today, are they a candidate to work with you?
Of course. Yeah, I mean, I would say, think of me like a coach in a way. So you can come here because you've had like damage and or injury, or things aren't working at all, or I can take you, we can look at working from, standard mediocrity good to just the next step up. Actually, working with the next step up is actually a lot more fun, because we get a lot more faster progress rather than kind of, trying to unglue and unstick old things. We already have a pretty good baseline. Now it's just upping that game and pushing more boundaries and testing new things and seeing how your body responds. So yeah, I don't just fix problems. I also help facilitate better.
Excellent. Okay, so a question, there's a lot of recommendations that come women's way as they age about hormone replacement therapy being an answer to sustaining sexual drive. What do you have to say about that?
Now, I don't know a lot about the hormonal response. I've heard just generally some general good things, and most of the hormonal replacement is going to be to keep the lubrication kind of happening, and kind of some of that, just the biology running, because use good lube to make sure that your lube, there's some good, like a good one with Good Clean Love for a lot of women who are a lot more sensitive in terms of some of the lubes, and so the more we can, the general rule is use it or lose it. So dilation insertables are actually something that's almost recommended for women as they get older, to make sure that we get it's like stretching your muscle and making sure it's still movable and flexible and malleable. If you don't do that, it starts to kind of tighten up and becomes more problematic. And so, the hormone replacement can help keep that supple and kind of agile, as well as insertables, be it whatever that might be. And the lubrication are the key things when we're looking at that. So it kind of just makes it easier, but it's not necessarily going to do that desire issue as much. But it's going to keep the body running like it's younger.
I think this is a related question on whether or not when somebody in their 50s, a woman in her 50s, is still on birth control, will her desire for sex increase or decrease when she stops the pill?
I've seen both. I've seen women, once they hit menopause, now it's almost like their mindset is going, good, I can never get pregnant. And all of a sudden their sex drive goes through the roof. I've also seen women go, oh, I'm no longer a woman anymore. And bah, I'm like, drive just drops down to nothing. So it's almost like a case by case basis we have to check.
Okay, that was a really good sort of, no answer. It could go either way, but and I
think everyone's different. I've seen it goes both ways.
Yeah, for sure. I think that's probably one of the most complicated things women face when they get older is the variables involved in hormones that are decreased, how you use testosterone, the difference between bioidentical hormones and the conventional therapies that gynecologists are prescribing. And I guess to the listeners who are asking similar type questions, we're going to get to that in a webinar session for sure, because it is very confusing. Dr. Hrushka and I had a discussion before the session started about a man who wants to preserve his desire and his drive can take one pill. He can take one pill for a moment in time experience, or he can take testosterone as a therapy that he monitors. And again, it's one injection, one pill, one cream, whatever the case may be. But if a woman wants to achieve the same results, she's going to have a handful of drugs. She's going to have pills. She's going to have creams. She may need vaginal rejuvenation. She may need all kinds of things. And I think that's a bit of an indicator of complexity, inequities in research. But what are your thoughts on that, Dr. Hrushka?
I would say, like, the only thing that's going to guarantee an erection is pripavravine, which is the injectable, at the time. So even if they take Viagra, if there's performance anxiety and issues, penis ain't going to work. It's going to drop like a lead weight. And so although men have more options that seem to be working more, the mind is still the biggest one. And so a lot of women rely on trying to fix through it externally, when in my experience, most of women's biggest block is their mind. Women tend to carry way more baggage psychologically regarding their sexuality than men, and they want to fix it through an external system. They don't want to think about fixing the blocks and the walls and the contaminants. And so if we fix those stuff, women's bodies tend to work better than guys.
I think you nailed it when you have referenced many times that this is complex, and women's sexuality is a complex system. So if a woman during sex, if it hurts to have sex, what would be your first recommendation to a woman who it's just simply not comfortable?
I need to know what that uncomfortable is all about, because there could be cysts, there could be like fibroids, there could be a whole bunch of biological stuff, and I want to rule out the biology first. So, and that could either be going through, to your GP, to your OBGYN, or a urologist who specializes in women's sexual health, or the sexual physiotherapy. If we rule out all of the biology first, then most likely it's going to be vaginismus, which is usually I call it a stress-induced or psychologically induced through anxiety, tightening of the muscles that causes that pain. And so then I can work on that one much more easier. But I want to rule out all of the biology first. And there's a whole bunch of possible biology causes, vulvodynia, and depending on when the pain started and how the pain is and where the pain is located. So that's the first step that I would recommend, is rule it out first, and then we can chat.
Thank you for that. One of our viewers wants you to talk a little bit more about the graph on the play challenge and supply demand. And it might be helpful if the person who asked this question elaborated a little bit more as you start to walk us through that.
I might need more direction for that one.
I hear you. So I'm not sure who asked that question.
You said you would talk about it after there's a graph, or you would just talk about more examples of play or restriction to increase desire, I believe.
Can you run the question for me so I can re-scope it and kind of get my scope around it again?
I think there was like 5 different questions within that one, because I think you could, go many different directions with that. You had just said, maybe if I have time, I'll touch on the graph that works around supply and demand.
Well, I mean, a good example here, I brought this one up. So David Snarch, who is a sex therapist who just recently passed away, talked about what's called the crucible model. And so one of the things, I mean, there's not a graph for the supply and demand. It's just a nice, simple supply and demand graph. But this one relates to kind of where a lot of people want to be in a level of comfort and safety. And what happens is with comfort and safety over time, because they're in a safe relationship or too comfortable, it leads to boredom. And then it leads to kind of a pattern of unresolved detachment here. And then it kind of spirals into unresolved issues and, into terms of termination of those activities. And so when we're looking at trying to help with individuals who are, let's say, in a, if there's a supply and demand, if the supply is too high, then you're going to get bored because there's no challenge to this. So I'm trying to help relationships look at playing with growth, which basically requires to kind of take more risks. But that's going to cause anxiety. And as we do that, we get to new levels of growth, which changes that level of commitment and trust in that new area. And so this kind of model looks at balancing, growth potential versus being in a comfort and safety system. And you're going to go back and forth in and out of these kind of pretty much for your whole life. But if you have too much of one, you're either going to get really tired or you're going to be bored. And so it's about finding out what's in your, what all those little factors and variables are, what's going on in terms of desire to help you get a good understanding of what you might be lacking or what you might be wanting or what you might want different. I've had people just, they've had missionary sex their whole life and they've not nothing else. And so they don't know there is anything else until we try that. Or if there's someone always available, they like the one that the bad boy, the one that you can't get. So it's understanding your psychological arousal templates. You might, if there's lots of insecurity, you might want that person to be very highly available, and then you might not have the issue, right? If that person is very available, you feel validated all the time, you feel like they want you all the time, it's great. It's everyone, it's kind of looking at everyone in a different dynamic and seeing how your dance works with the other person, and it's that relationship dynamic. Hopefully that answers some of that.
I think that was Keely, and I know that if we had another hour to chat with you, I really would like to I would have done a deep dive into how you work through arousal templates and mindset and supply and demand and all of the dynamics that go around with that, to have a great conversation with your partner about creating the best situation for magnificent sex, because it's like you've said, it's all very complex, and every sort of macro piece of information you have given us this morning, there's just so much underneath it that needs to be explored to go from even good to great and potentially magnificent. So I wish we did have another hour. We're getting close to the end. I have a couple of Women's Health Coalition questions I'd like to ask you, which will also give a final moment to anybody on the line to that one question they wish they'd asked. Now would be the time to think about it. So my 2 questions are, the Women's Health Coalition, as I said, is an advocacy organization, and that includes advocating for health system change, access to therapies, that kind of thing. Is there anything that is preventing women from accessing your service that you think the Women's Health Coalition could work on that would make it more available to women, would help them understand what the advantages of a sex therapist is. What would you want to ask of us, of the Women's Health Coalition?
Okay, so the first question was, is there anything limiting or stopping that from happening? Well, I would say, I mean, in order to see a psychologist, usually, I mean, there's a fee associated with that. There is no government coverage for that. I'm part of an EPIC group, so there's 4 agencies have got together, and we've actually done a push to get the government to support, you know, counseling, because you can go to a physiotherapist and you can get sessions covered, but you can't go to a psychologist and get it unless it's through Alberta Health, and they don't have usually lots of specialists in those areas. And so if you want to support that petition, it's under, I can probably forward it to you. It's under the EPIC. We have an EPIC website. So there's a petition that we've done that just got put forward in front. And that's basically saying, can we get people, like all Albertans, to be able to get even a few sessions of coverage with therapy to cover, you know, for me, if you have extended healthcare benefits or insurance, those will usually cover Blue Cross, treaty status. I'm approved for treaty status individuals to be able to kind of do that. There are a few, I have some sex therapists in training that I'm working with here. So those are the only limitations. You don't need a doctor referral to come to me unless your insurance company requires it. Those are your main limitations. Sometimes you can get your EAP if you have a EAP through a company to pay for it, because they might have it with one particular group or individual. And then they might say, no, we only work with this. But you say, well, this is a specialty that you guys don't have. And they have paid for it or covered some cases.
So how easy is it for women to find a qualified sex therapist? So if I Google sex therapist, is your name going to come up?
Yeah, it should. Right now, the only ones in Alberta are the ones I've trained, except for one, I believe. And there's not a lot of us in Alberta. I have trained, well, one retired now. So there was 4 of us, and now there's 3 of us, and I've trained all the other ones. There's me, there's Jason Jones. I think there's, in Calgary, 2 of them are retired. So I'm trying to think who's in Calgary. There's probably only about 4 that are completed, 1, 2, 3, maybe 4 right now in Alberta at all. Yeah, so again, that are psychologists and then sex therapists. I have about 4 or 5 right now that I'm training. So you don't have to necessarily have a full sex therapist, but I tend to say recommend someone who's going through the process at least, because there's a whole bunch of training they have to do. Or just do your good due diligence on if someone is a sexual, if they're dealing with sexuality stuff. Some people might be still running on Masters and Johnson 50 years ago stuff because they don't require, AASECT requires us to get continuing ed training every year, whereas some individuals, I don't know what they know. So that's the only question that I don't have if they're not AASECT approved.
And is there a website? So, I mean, I can go to the College of Physicians to find a doctor. Is there a website or a college?
AASECT.org is the AASECT one for all of pretty much the world, but it's mostly North America. Other than that, you're looking for individuals within usually private practices. Like to me, you got to go to Insight Psychological and then I'm there. But if you type in like Edmonton sex therapist, I probably should be the first one coming up. Okay. I know I'm the highest trained one, but I don't know. Partly that's all about marketing, right? In terms of who's paying more to kind of be higher on top type thing.
I guess where I was going with this is, you've probably excited a lot of people to think about it. And the goal of the Women's Health Coalition is to get people to talk about it and pursue the supports that they need when they need it and making sure they can find it. And so my last question in this sort of avenue is, if somebody wanted to see you as a new patient or a couple wanted to see you as a new patient, what's the wait time?
I'm not sure right now because my admin would know that. Last time I heard, I'm a bit popular now. Probably about 2 to 3 months. But I've also had clients phone in and got in the cancellation list, and they got in the next day. It's just like, hey, I phoned in yesterday, I got in today. It's like, and other people are waiting 2 months. So it's kind of as clients kind of move or cancels, and it's just being able to get on a wait list and be able to do that. And usually I say once you get in, just book in advance because people kind of, well, I'll book later on, and then it's, you know, a month later or 2 months, now they got to do the same thing or get back on the cancellation list. So
Right. This is a different kind of supply demand, and that's one of the things we're dealing with often with the Women's Health Coalition, and it would apply to gynecologists and you know, pelvic floor health specialists, and a lot of it depends on whether or not there's private coverage for it or public coverage, and that adds to the complexity of women's health and sexual health. So
yeah, it doesn't have to be me. I guess the good advantage, because I have about 4 other therapists here, or 5 that are kind of working in those areas and kind of having some different passions. But I'm supervising them all. So if there's a question that does come in and they want to get in faster or start the process, they're usually consulting with me, and then kind of I'm working with them to kind of answer those questions.
excellent. Well, we are getting to the end of our session today, and I really want to thank you on behalf of the Women's Health Coalition for sharing your expertise, your humor, and your very, very open conversation. That's exactly what we wanted to have, your expert advice. I'm with certainty people are thinking about things differently, and you've even given me some stuff to think about in terms of our advocacy agenda. I would love to see that petition. So I will make sure I get that as well. Any final thoughts you'd like to leave with our group before I go into some wrap-up comments?
I guess I just one thought that just popped up in my head is, I mean, as we're talking about people and exploring new things and finding things, I think the favorite statement that I remember hearing is from someone I know who said, like, oh, I'm not supposed to like that, but my body sure says that, you know, keep doing that, but I'm not supposed to like this. And that mindset, how it tends to kind of almost contaminate or slow things down. And so it's sometimes your body knows exactly what it likes. You just got to be able to get at learning how to listen to it and kind of find that. So,
you know what? I can't help but ask one more question because of what you just said. How would you encourage a woman, or even for that matter, a man, if they like something or want to try something? How do they get over that resistance to say it out loud? What would you tell them as a final piece of advice?
It could be, I mean, I don't know if there's a nice simple answer to that one. I want to find out what's running through their head that's causing that belief system, that taboo, that dynamic. And that's where the psychoeducation comes in, typically to help teach people, or help teach people how to do that safely. Because I have some people like, yeah, it's a little bit edgy. Here's how to do it safely so you don't hurt yourself, even if it feels good, versus doing it that way, because you're going to get into problems pretty soon if you don't change what you're doing. And so just kind of ask questions and get educated is the first step, so that we can find out what that is. Because sometimes saying it out loud is harder to do than doing it by yourself, so to speak, or whatever you're doing. So there's all these different stages that I typically will work on, is teaching, educating, answering questions, being able to ask questions before we get to say it out loud. And then that's kind of, once we say it out loud, then it opens up usually another door to be able to move forward.
So what I hear you saying is, it's not reasonable for me to expect my husband to read my mind?
Correct.
Ah, darn. Okay, well, again, thank you for this very open, provocative conversation, and thank you to everybody who signed in and shared your thoughts and questions as well. Just to let everybody know, our next webinar will be held in September. We're going to take a summer break. We've held 4 sessions so far, learned a lot from them. You'll see some new things come out in the fall. If you are a member, you will be notified of the 2021-22 schedule in August. We would hope to map out the whole thing, so you'll get an idea of the rhythm we're going to create for the next program season. If you're not a member, you should sign up for our e-news. That's another way that you can stay in touch with what we're doing. There will, in all likelihood, be a conference, a patient and clinician conference in the new program year. Another thing to remind you of, what our webinars are free to members, and they're relatively low cost anyways, but they're absolutely free to members. And any conferences, breakfasts, anything like that we introduce once we can get back to in-person gatherings are also at reduced cost to members. Individual membership is only $25 a year. And if you're part of an association, your annual fee a business or association, your annual fee allows all of your employees and members to attend webinars and our activities at the member rate. And so those rates to join are also quite low, $125 for association members and $250 for businesses. And I'm taking some extra time to talk about this because our ultimate goal is to create a movement to speak openly, learn, and engage with purpose about women's health. And that means we need to grow our network, and we want more people talking about it with more courage and more forthrightness about things that often have been whispered about, or you don't know who to talk to. And so growing the movement is our core way of making sure that we can advocate and make change in the health system to improve health outcomes for women's health. So again, if you're part of an association or part of a business, I would ask you to go and talk to the person who runs that organization and say, hey, I think there's enough of our members who are women that we should be doing this as an association, or we should be doing this as a business. So that was my moment to say, help us grow our movement. If you have any questions about that, you can reach me at any time at info@thewhc.ca. I don't know who's all online this morning, but I also wanted to take a moment for you to meet the Women's Health Coalition team. We are entirely a volunteer organization. So if you have your video off right now, I'd encourage you to turn it on and give a wave. We don't have time to introduce everybody, but certainly seeing these tireless volunteers for real and giving them, a big applause for a moment. None of this would be possible. The strides we've made in advocacy would not have happened without an amazing team of volunteers. So again, if you want to learn more about what we're doing, just go to www.whc.ca. So thank you very much and enjoy the rest of your weekend.
Thank you.
Thank you.
Thank you.
Thank you.
That was great. Thank you.
Thank you.